Hello everyone. In this session, I am highlighting few points in ectopic pregnancy, that what all clinical varieties are there and what all signs and symptoms the woman exhibits when she have ectopic, and what all diagnostic tests are there to confirm the ectopic pregnancy. So before you watch this video, I'll suggest you that I had already been previous video of ectopic, where I have covered the various sites of implantation, what all risk factors are associated with the ectopic pregnancy. So you can go through with that video, and the link of that video is given in description box below. So what all clinical varieties are there in ectopic pregnancy? So there are three: acute, unruptured and chronic. So acute, it means this is the emergency situation where woman can land up in heavy bleeding. There is a massive intraperitoneal hemorrhage that could be because of tubal rupture. The tube is being ruptured and then whole conceptus and the bleeding comes out in the peritoneal cavity. It is because of that, or it may be because of tubal abortion. The whole conceptus and all other products will come out through the tubal opening and then enter in the peritoneal cavity. So in either of the situation, finally the woman bleed massively, and because of that the woman have sudden symptom suddenly. So the onset is sudden. It means all the symptoms are appearing suddenly, okay, because of this intraperitoneal bleeding. And the second one is unruptured, where the conceptus lies in the tube extends but it doesn't rupture. So this is the second variety, which is least dangerous. And the third one is chronic, where maybe the tube get ruptured and it heals. So there may be some bleeding and some fluid that accumulate in the pouch of Douglas, okay, on the posterior aspect, and the signs are not too sudden. It means there is a slow progression of disease. There is a slow appearance of symptoms. So that is the chronic one. So these are the three varieties: acute, unruptured and chronic one. So what all signs and symptoms the woman may have with these all varieties? So there are the classical triad symptoms that every ectopic woman can show these all symptoms. The first one is the amenorrhea, that is absence of menstruation, because already conceptus is there. So because of this conception, the menstruation remains stopped. Yes. Second is abdominal pain. The woman may have very colicky, stabbing like or tearing like pain. It may be located in one side, unilateral, maybe both side, bilateral, or maybe generalized abdominal pain that is located in the lower abdomen in a hypogastric region. So why this pain? Because if it is unruptured tubal pregnancy, in that condition, when the conceptus is growing inside the tube, what happened? The peritoneum, the overlying peritoneum is also stretched, and because of this the woman may have abdominal pain because of the stretching of the tube. And if it get ruptured, then what happened? The massive blood comes out through this and it accumulate in the peritoneal cavity. So because of that hemoperitoneum, the peritoneum may irritate and that may cause irritation in the peritoneal lining, that is peritonitis may appear, and because of that sometimes the fluid and the blood is that much that it causes irritation in the diaphragm also. So when the diaphragm gets irritated, then the woman may also have shoulder tip pain, because it is a referred pain as it involves the phrenic nerve also, okay. So the abdominal pain is the second symptom. Now the third one is the presence of vaginal bleeding. It can be a spotting, or it can be a continuous dark colored bleeding, or it can be the whole sludging of the endometrium in form of decidual cast. Because what happened, how the pregnancy continues, because of the HCG release, the beta HCG, which is released from the trophoblastic cells from this conceptus. So in normal endometrial cavity, what happened? There is more space to grow more. So there will be more beta HCG level that is releasing continuously in early pregnancy. But in tubal pregnancy, what happened? This is not providing, the tubal space is not that much to release more beta hCG to continue the pregnancy. So because of decrease in beta hCG also causes decrease in progesterone level that maintain the uterine lining. So as there is less progesterone, because of that the endometrial lining will no more be maintained easily. So there may be a spotting, the vaginal spotting could be seen, or even with a drastic decrease in progesterone level, even whole endometrium, whole decidua can comes out in form of decidual cast. But suppose if the woman had ruptured ectopic pregnancy, then in such condition we need to check pulse and the vitals also, because with this massive intraperitoneal bleeding, the blood volume is drastically decreases, and that can cause the decrease in blood pressure, hypotension, and the pulse rate is also increases, that is tachycardia. So woman can land up in the feature of shock. So we need to check the vitals also to rule out the features of shock. The woman looks pale because of decrease in blood volume. Yes, so pallor, hypotension, tachycardia, these all need to be checked so that we can rule out the feature of shock. And even though it is too severe that the woman may have vertigo or even syncope, so we need to check out the feature of shock if ruptured ectopic pregnancy is there. Okay, because these all things indicative of that the tube is being ruptured and whole conceptus and the bleeding is there in the intraperitoneal space. Okay, so we need to rule out that. And when we do per abdominal examination, then at that time the abdomen looks tense, tender, rigid, or there may be a presence of muscle guarding as well. So why it is tender? Because it is when you are doing abdominal examination, when you are putting your hand over the abdomen, the woman may have pain. That is called tenderness. So this is because of intraperitoneal bleeding, and because of that bleeding the peritoneal lining gets irritated, and that cause this irritation cause pain. And if the ruptured pregnancy is not there, in such condition also the tube becomes stretched with the conceptus, and that will also causes stretching of the peritoneal lining. Yes, and when the peritoneum gets stretched, again it may cause the pain. So there is a presence of tenderness and the abdomen is rigid, and sometime muscle guarding would be present. It means voluntary or involuntary tightening of muscles of the abdominal wall could be seen because of the pain. Okay, so this could be seen in abdominal examination. And if the bleeding is too heavy, if the intraperitoneal hemorrhage is too heavy, then it can cause bluish discoloration around the umbilicus also. So this is called Cullen sign, where bluish discoloration could be seen around the umbilicus on abdominal examination. And when we do bimanual or per vaginal examination, then we can find out the vagina is pale, that is blanched, and cervical motion tenderness could be seen. It means when we are putting our fingers in the cervical region, then when we move side to side up to the lateral fornix, when we move side to side, that can cause pain in women. Because if the ruptured pregnancy is there, tubal pregnancy, in that condition the blood comes out and it can lie in these pouch of Douglas and around the uterus. So when we move the cervix, which is lined by the peritoneal lining, that can also irritated by the collected blood. So because of that the woman may have cervical motion tenderness. And sometime if unruptured ectopic tubal pregnancy is there, then through the lateral fornices we can felt some adnexal mass also. So that indicates that the woman is having unruptured tubal pregnancy. And here the uterine size is also normal, because here the conceptus is not lying in the cavity, so it is growing somewhere else. So because of that the cavity size remain unchanged. It means the uterus is normal in size. And suppose if the bleeding is too heavy, that it covers most of the part of the uterus and underlying adnexia, and it surrounds whole structure, then in such condition when we do PV examination, then we feel bogginess, that is the feeling of fullness, especially at the lateral fornices, because it is feeling like something is lying within the fluid thrill. Okay, so these are the signs and symptoms through which we can evident that whether the woman is having ruptured or unruptured type of ectopic pregnancy. Now let's see what all diagnostic tests are there to detect the ectopic pregnancy. So the best test is the serial serum beta hCG level, where we can continuously monitor the beta hCG level in the serum and identify whether the woman is having normal intrauterine pregnancy or ectopic pregnancy, where the concept is implanted somewhere else. So how this serum beta hCG helps in detecting ectopic? Because in normal intrauterine pregnancy, what happened? The concept is implant in the endometrial lining of the uterine cavity, where it embeds and the trophoblastic cells releases beta hCG, where they receive more space. Okay, but here in tubal pregnancy or the pregnancy, ectopic pregnancy somewhere else, what happened? The trophoblast is not getting proper space to release hCG more and more. Okay, so after a particular level, what happened? The beta hCG level drops down in the ectopic, wherein normal intrauterine pregnancy, what happened? Initially up to 8 to 10 weeks. It means in first trimester the beta hCG level rises more and more. It just double in every 48 hours. So in normal intrauterine pregnancy, the beta hCG level just doubles in every 48 hours. Okay, if we monitor, and thereby after 8 to 10 weeks it will goes down and it remains plateauing. It means in a constant level. But in ectopic pregnancy, what happened? In early pregnancy, the beta hCG level doesn't doubles, okay, as in normal intrauterine pregnancy, or it drops down. So by this serum beta hCG value, we can detect the pregnancy is intrauterine or not, because if the value goes down, it means it is ectopic pregnancy. Okay, or it reaches plateauing, and if sudden fall is there, then it indicates the abortion could be there. After confirming with the beta hCG, we can go with the transvaginal sonography. This is the most accurate method. By this sonography, firstly we can see that there is no conceptus in the uterus. It means the gestational sac is not there, the uterine cavity is empty, and this gestational sac could be seen in the adnexal. It means there may be adnexal mass in the ovaries or tube, where we can detect, yes, the whole conceptus is not lying in the uterus and it is somewhere else in tube or ovary. So that could be seen by TVS. Okay, and if we do Doppler ultrasound over there, then we can find out one ring of fire over the adnexal mass, and it is slightly separated from the ovary. So this ring of fire means there is an increased vascularity around this whole conceptus, and this is looking like as a fire of ring on the tube. Okay, so in the tube we can see in the TVS that there is a ring of fire which is slightly separated from the ovary, and it is not in the uterine cavity. That is called the bagel signs or the tubal ring of fire. If the woman is having amenorrhoea, she is having abdominal pain and her urine pregnancy test is positive, then next we'll do transvaginal sonography and we'll find out that there is no uterine sac, the gestational sac in the uterus. Then we'll go with the beta hCG level, serum beta hCG level. So there is a discriminative zone. So the discriminatory zone is differ book to book. In some book it is written that it should be 1500 milli international unit per ml, and in some book it is written 3500 milli international unit per milliliter. But this discriminatory zone is completely depends on doctors, what they practices in their clinics. So if the value of serum beta hCG level goes below this discriminatory zone, then what we can do next? We can repeat the test, because in single attempt we cannot come on conclusion that the woman is having normal intrauterine pregnancy or ectopic. So on repeat serial serum beta hCG level, if we find out that the discriminatory zones level is just double, it means the whatever the value we get is just double in next 48 hours. It means it shows that there is a normal intrauterine pregnancy. But suppose if the value doesn't doubles and it remain plateauing, it remain in a constant phase, then it is 100% confirmed that it is ectopic pregnancy. So with the serial serum beta hCG value, we can detect the woman is having ectopic or not, because as I have mentioned that the property of beta hCG in early pregnancy is just doubling. So suppose if you are getting 1000, the value of 1000 today, then after 48 hours you will be getting 2000. Okay, so thereby the value of beta hCG increases in normal intrauterine pregnancy in earlier weeks, but in ectopic pregnancy it won't be double. So thereby you can detect that the woman is having ectopic or not. But suppose if the value of beta hCG goes drastically down, then it confirms that the woman have abortion. Okay. Apart from these beta hCG and transvaginal sonography, there are some other tests but are not routinely practiced, and in them one is culdocentesis. It means we are using a needle that to be placed through the lateral fornix in between the vagina and the rectum and will aspirate the fluid or the blood that is collected in the pouch of Douglas. So once we collect this sample, we can keep in the tube and check if it is non-clotting. Suppose the blood is not clotting, whatever you aspirated is not clotted, it means there is a ruptured ectopic pregnancy. Okay, and laparoscopy could be done, and this is the best or very accurate method to identify ectopic, but it is to be done when the surgical interruption could be taken place. So it is not to be done just to confirm, but if you want to conclude on therapeutic reason, then you can go with the laparoscopy, where one scope you are inserting through the abdominal wall. So that scope gives direct visualization over the ectopic, where the exact site is there, where it is, whether it is in ovary or it is in tube or it is somewhere else in the cavity. So it gives direct visualization over the ectopic pregnancy. And along with that, laparotomy could be done in least cases where the woman is hemodynamically unstable. In that cases, we cannot go with this all procedure. We just go and treat the woman as early as possible. So laparotomy, where we can incise the abdominal wall and just treat the woman. Okay. Somehow in other condition, dilatation and curettage could be done, but it is also limited. And but what is the reason behind this dilatation? That by taking an endometrial biopsy, we can find out that the chorionic villi are present or not. Okay, so through this curettage, if the chorionic villi are present, then it is indicative that there is a failed intrauterine pregnancy. But suppose if any chorionic villi are not present, and in that cases we can come on conclusion that yes, there is an ectopic pregnancy, but that is lying somewhere else. Along with that, serum progesterone level could be monitored, because in normal intrauterine pregnancy the value is more than 25 nanogram per milliliter. But in ectopic the values are not that much, it drops down. As I have mentioned, the serum beta hCG level is not that much, as trophoblast is not releasing more and more. So progesterone is also declining in this. So here if the value is less than 5 nanogram per milliliter, then it indicates that the ectopic could be there. So here we have seen various diagnostic tests through which the ectopic could be confirmed, but the most accurate one through which we can confirm is the serial monitoring of beta hCG and the transvaginal sonography. So these are the confirmatory one, and some are the diagnostic surgeries through which we can confirm the diagnosis, as well as we can therapeutically go with the surgical management as well. So here in this lecture we have discussed what all clinical varieties are there in ectopic, what all basic signs and symptoms are there that exhibits through ruptured or unruptured ectopic pregnancy, and what all gold standard techniques are there to detect ectopic pregnancy. Thank you.